to my heart. Oh. So I have no disclosures that are relevant to today's presentation to make. And here are the learning objectives, which I believe have been circulated in advance. So just as a way of a brief background, as most of you know, 30% of persons with epilepsy have drug-resistant seizures. And focal epilepsies may be surgical treatable, but the key principle in pre-surgical evaluation of these patients is identification of the epileptogenic zone and resecting it if it's possible. And the definition of the epileptogenic zone is the brain tissue that is necessary and sufficient to generate seizures. And this can only be identified post-operatively. So in pre-surgical workups, we are trying to identify markers of the epileptogenic zone. And here are the different zones that you are probably familiar with from the work of Luters and others. Going from the top down here, I'll focus on a large part of my talk on the epileptogenic lesion, which is shown in blue here. And these are theoretical concepts. Next, there's my dog, is the irritative zone, which is identified by intrathecal discharges, or the HFO generating zone, shown in green here, followed by the functional deficit zone, which can be identified by interictal PET and SPECT, which I'll discuss. And all of these can be performed as an outpatient on scalp EEG, for example. Then the seizure onset zone is arguably the most important pre-surgical marker of the epileptogenic zone, and this is shown in red. And this is identified by ictal EEG recordings, as well as ictal SPECT. And lastly is a symptomatic or symptomogenic zone, which is the cortical area that results in expression of clinical symptoms in the patient. So in the most straightforward cases, all of these zones overlap one another. In more complicated ones, there may be partial overlap, or in others, there may be even less complete overlap. So the key pre-surgical investigations are to identify these different zones, most notably the seizure onset zone. So with that in mind, the outline of my talk will be about structural MRI first, okay? And I'll actually talk about it first as it relates to outpatient investigations, first seizure, diagnosis of epilepsy, and so on. Then we'll talk about pre-surgical use of SPECT and PET. And lastly, I'll talk about advanced neuroimaging techniques, focusing on two specific techniques, EEG fMRI and post-ictal arterial spin labeling MRI. So why image an epilepsy? It's important to do so to detect lesions that may be causally related to epilepsy, estimate prognosis, plan appropriate care, and for pre-surgical evaluation. I believe there's a chat here. I'm not sure if I should be addressing this.
No, I can moderate it for you.
Oh, okay. Sorry about that. Yeah, because it's a little bit distracting. That's good though. If there are some questions, feel free to interrupt me, Dr. Bowie, okay? So in pre-surgical evaluation, it's important to identify a potentially epileptogenic lesion because the chances of seizure freedom doubles if a lesion can be seen. So when is imaging necessary when first managing persons with epilepsy? You should image in a patient that has focal seizures, either by history or EEG, developmental regression, history of status epilepticus, or an atypical presentation of either of these epilepsy syndromes. There are, of course, other indications for imaging. And we don't typically or exceptionally image patients with fairly typical genetic generalized epilepsy syndromes or typical central childhood epilepsy with central temporal spikes. People may disagree about that, but in general, we don't image these patients routinely. So here's an old study. It's an evidence-based review put forward by the American Academy of Neurology back in 2007 about the usefulness of imaging following the first seizure. Essentially, they deduced that brain CT or MRI is probably useful with a significant yield of at least 10%. So their recommendation is that brain imaging using CT or MRI should be considered as part of the evaluation of a person with their first seizure. We would recommend imaging with a cranial MRI if the resources are available, but certainly at the very least, a CT scan should be performed. So what about patients with newly diagnosed epilepsy? So this isn't the first seizure, this is newly diagnosed epilepsy. So again, in an old study of 103 patients with newly diagnosed epilepsy, the MRI scan, properly obtained and properly reviewed, was normal in about 75% of the patients. So put another way though, 25% of patients with newly diagnosed epilepsy have an abnormal MRI scan, which may be potentially epileptogenic. And the most common, at least in their study, were malformations of cortical development, focal atrophy, tumor, strokes, and hippocampal sclerosis. So here's some other common abnormalities. Potentially epileptogenic abnormalities with focal epilepsy. I've already listed a few of them. There's also low-grade tumors, trauma, vascular malformations, and granulomatous disorders. And I'll just show you a few examples. Here's a very common cause of focal epilepsy, hippocampal sclerosis, shown in the coronal flare images here, where you can see atrophy of the right hippocampus and T2 hyperintensity compared to the contralateral side. Looking at coronal T1 weighted images, here's a normal hippocampus. It's a bit blurry, these images, but you can see, again, the atrophy and loss of internal architecture that you can nicely see on the contralateral side. Here's an example of the focal cortical dysplasia, characterized by abnormal area of gray matter. So it's iso-intense to gray matter, and it's in an area where you shouldn't see any gray matter, in the frontal lobe white matter. And in this particular case, it's also T2 hyperintense. It may not always have to be T2 hyperintense. And some cortical dysplasias can be quite insidious and difficult to identify. Here's an example of subependymal nodular heterotopia, where you see heterotopic nodules periventricularly, and oftentimes the ventricles themselves are abnormally shaped, okay? So in the outpatient setting, what is the prognostic value of imaging? This is a very old study carried out by in the Mayo Clinic, and it basically shows that the relative risk of recurrent seizures is doubled over a several-year period if a lesion is present. So that's very important to identify whether you think seizures may recur in a patient, and more importantly, if they have an identifiable lesion, then you may be more likely to pursue pre-surgical investigations if they fail at least 2 adequately trialed anti-seizure medications. So if there's one slide I would want you to remember and understand, it is this one, okay? So this slide, I think, is really, really important, okay? As I hope I've already mentioned, MRI is a key epilepsy imaging investigation, and it's even more important in the pre-surgical evaluation of patients with focal epilepsy. Now, I'm part of the neuroimaging task force of the ILAE, and we put out a paper in 2019 giving recommendations for structural MRI in patients with epilepsy. So I would encourage you to read and understand this paper. We strongly recommend following what's called the Harness MRI protocol. And the Harness stands for Harmonized Neuroimaging of Epilepsy Structural Sequences. And there's 3 key sequences in this protocol that every proper seizure protocol should have in every epilepsy center, okay? The first is a 3D volumetric acquisition of T1 weighted images with 1 millimeter isometric voxels. And this is good for detecting subtle malformations of cortical development, blurring of gray-white matter, for example. The next is a volumetric acquisition of flare images, again with 1 millimeter isometric volume, voxels. Again, it's very important for identifying subtle lesions that have T2 hyperintensity, such as some malformations of cortical development. And the third is to properly evaluate for hippocampal changes. And this is a 2D acquisition of T2 weighted images with voxel sizes of 0.4 by 0.4 and 2 millimeters, with notably no interslice gap, okay? And this also has to be acquired perpendicular to the long axis of the hippocampus to allow adequate visualization of the hippocampus and mesotemporal structures. What's also equally important, and I'll highlight in the next slide, it's very important to provide detailed clinical information on your MRI requisition. It's important to help the neuroradiologist help you. If you put on an MRI requisition, seizures NYD, they won't perform a focused review of the MRI scan. They'll do the general review and probably look at the temporal lobe. But if you tell them, I suspect left mesial frontal, then they'll maybe look more carefully there, okay, in addition to the rest of the brain. It's also very important to view the images yourself and with a radiologist if you have any questions. And you can also obtain a second opinion from another neuroradiologist or from another epilepsy center. So I think this slide is really, really important, and all of you should try and remember and understand this. Now, I just want to open up the chat, okay, here, and I just want people to comment about where they think the seizure onset zone is in this patient. And this is a patient of mine that I monitored last year. This is a 37-year-old female who came from another province, who had seizures since the age of 6, and she was having 1 to 2 seizures per week lasting a minute, and she's failed multiple anti-seizure medications. And her seizures begin with a sense of spatial disorientation in the left visual hemifield that spreads to the right over 10 seconds. And she says that things are distorted. And for example, when we're rounding on her, she knows that we're standing upright, but she sees that we're actually twisted to 45 degrees and almost floating in midair. Following this, she has forced head deviation and clonic jerking of the head and eyes to the left while she's aware. And then she'll try and hold on to things because the world is kind of tilting for her, and she may actually fall down. And during this entire time, she is actually aware, but she may be briefly disoriented and tired afterwards. So if you were, okay, so if you were to identify where you think the seizure onset zone is, where would it be? So I hear the occipital lobe, maybe left, but may I ask you, like the seizure begins with a visual phenomenon on the left side. So I would agree that it's on the right side of the brain. So right posterior quadrant, thank you, right occipital. So what, can we be more serious? Parietal temporal is pretty good, actually. So parietal temporal, good. So this seizure probably is beginning somewhere in or around the right parietal lobe, because that can result in spatial disorientation, as well as disorientation, and it probably is on the right side because things began on the left. And then there's also clonic head deviation and jerking to the left, suggesting probably anterior propagation. So you should be looking around the right parietal occipital temporal region. Well, I'll tell you, this patient.
Quick question. Yeah. When you say the world makes no sense, can you clarify what she means? Is this an aphasic or dysphasic?
Spatially, no, spatially. Spatially, like she says, for example, she sees, like when we were rounding, she said, for example, I know you're standing upright, but you're actually floating in midair at a 45-degree angle. That just doesn't make sense, right? And then she doesn't know where doors are because they're basically distorted like that. So she's spatially, the world doesn't make sense. So she's leaning on walls because she doesn't know what is what, and she actually has to put herself down to the ground because she may fall.
Does she have a post-ictal neglect?
No, because these events are very, very brief. So I think this is important, and there's actually a case report which we published about this from the Neuroimaging Task Force to provide adequate information, because this patient has had 5 MRI scans over the preceding 10 years, and they're all interpreted as being normal, okay? So with the localization that we've come up with, I would like to ask someone in the chat line to identify if they determine whether they can see a lesion here. And of course, the answer is yes, there's a lesion here. These are axial T2s, axial T1s, and coronal T1 with GAD. Okay, I think it's probably hard unless someone speaks. So maybe I'll just point it out, okay? Yeah, exactly, perfect. So there is a cystic lesion in the right posterior parietal lobe near the midline. Okay, it's on T2, it's a T2 isointense or hyperintense, and it's isointense on T1, and it's non-enhancing. And this patient actually underwent epilepsy surgery during the same admission with us because she came from out of town, and she's now seizure-free. And this was actually, sorry, I guess I should have asked for a differential, but it's actually a DNET. It was actually a DNET, yeah. And now this patient is seizure-free. And she was having these seizures since the age of 6, and she was told that her MRI scan was normal. And you can see that this is probably a tricky area to see, to identify a lesion. So if someone is scanning through the MRI scan, they won't think to look at the vertex here, right? But we had a very strong suspicion, and we looked at this. And the lesion was present in the previous MRI scans, which we obtained. So again, it's really important to provide adequate clinical information. And even if it's reported as normal, the MRI scan, you should look at it yourself if you think you know where the seizures are coming from. All right, yes, great job, Dr. Wheel. All right, so next I'm going to switch gears and talk about SPECT and PET. Just want to see how I'm doing. Oh, I'm doing pretty good for time. Okay. So first I'll talk about single photon emission computerized tomography, or SPECT. It uses lipophilic agents such as HMPAO or ECD, and it's distributed proportionally to blood flow. So it's a marker of blood flow. And what's really important that some people don't understand, especially when you do an ictal SPECT, when the tracer is injected, it's trapped within the brain within a few seconds, and then it remains there for several hours. So essentially, when you inject the tracer, you're taking a snapshot of blood flow at that moment. And then when you take them down to the MRI scan, you're actually looking at the emission of the photons at that point, which reflects the tracer distribution at the moment of injection. So you're actually identifying blood flow at the moment of injection. Because the tracer is trapped within a few seconds rather rapidly, you can either perform interictal SPECT, where you may see hypoperfusion in the putative epileptogenic zone, or you identify the functional deficit zone, or at the beginning of a seizure where you can see hyperperfusion during an ictal SPECT. And as you can see here, sometimes it's difficult to identify an abnormality on interictal SPECT, but it's a little bit easier on ictal SPECT. And that's usually the case. However, it's important to know that while it's a very good study, and I'll give you some more data to support that, it's very labor intensive. It requires tracer injection within 30 seconds of seizure onset. So that means a healthcare worker needs to be at the patient's bedside or very near to inject a tracer at the first sign or EEG sign of a seizure. And that means one healthcare worker needs to be concentrating on that patient, or maybe two at the most, for the entire day. And it may take multiple days to get this injection. And this healthcare worker can either be an EEG technologist or a nurse or other person, depending on which center you work from. So many centers, including ours, perform subtraction SPECT, and that essentially involves taking an interictal SPECT, which, by the way, must be acquired following a period of seizure freedom of at least 24 hours. So they're seizure free for 24 hours, and then you can obtain an ictal SPECT, a SPECT injection during a seizure for an ictal SPECT measurement, and then you subtract the two images to get a difference image, which you then can superimpose upon other images to better identify areas of interval change in perfusion, specifically during the seizure. So the diagnostic performance of SPECT is shown here. The ictal SPECT performs much better than interictal. Ictal SPECT typically is associated with a 50% increase in blood flow, whereas interictal SPECTs can have no associated blood flow reduction, or up to 10%. A meta-analysis of all epilepsies combined shows, I think, a bit of an overestimation here, but at least in my experience, that ictal can have a sensitivity of 97 to 100%, which to me is somewhat astounding. And an interictal SPECT can have a sensitivity to identifying hypoperfusion abnormalities of 43 to 44%. So many centers, including ours, perform SysCom, which is the subtraction ictal SPECT, as I already mentioned, but co-registering it to MRI. And here's just an example from a previous publication of a patient with a left porencephalic cyst shown here on the MRI scan. And the patient had an interictal and ictal SPECT, and the subtracted data are then superimposed upon the MRI scan to give a better indication of where the hyperperfusion is in the potential seizure onset zone relative to the lesion. And the same can be seen in this patient who's MR negative, where a very small focus of hyperperfusion can be seen here, which in retrospect probably was there on the base images, right? Here's the ictal versus interictal, but it's obviously much more easy to identify this way. So now here's a case hot off the press. I just finished 2 weeks of call in the seizure monitoring unit. I literally presented this patient yesterday morning at 7:30. This is a patient I monitored for about 10 days. He's 48. He had focal impaired aware seizures with sensory onset, and his sensory symptoms were flashing white lights about every 30 seconds in both visual hemifields, followed by macropsia, and then right head and eye deviation, followed by alteration of awareness and oral alimentary automatisms. And there were a number of abnormalities on this patient's MRI scan. And it's quite interesting, without giving it identifying information, this patient came from another country because of the stigma associated with epilepsy to live in Canada, where he feels he would be less persecuted and with the hope of getting epilepsy surgery. So, and he just moved about a year ago to Canada. So his MRI scan showed what appears to be polymicrogyria along the mesial temporal region extending to the occipital lobe, as well as an abnormally shaped lateral ventricle and perinodular heterotopia. And also he had inverted hippocampi bilaterally, which is very unusual. It's usually unilateral and you see it more on the left than the right. This guy had it bilaterally. And we felt that the signal in the hippocampi here were good. So his interictal EEG showed quite abundant temporal epileptiform discharges on the right side, and relatively few low amplitude spikes in the right posterior temporal occipital region. So on Monday of this week, we obtained an ictal SPECT, oh no, it was actually last week, of a focal aware seizure. So all he had were those flashing lights, not much else, okay? And this is what we saw with the Subtraction SPECT co-registered to his MRI. Very focal hyperperfusion over what I think is probably back, unfortunately for him, the mesial occipital lobe here, and possibly involving the malformation of cortical development. So this information is very useful, and he's going to undergo intracranial EEG monitoring with the hope that we can maybe find something surgically treatable, although we suspect it won't be the case. But this is a very good example of how ictal SPECT can help identify the seizure onset zone preoperatively. Now I'll talk briefly about PET, and I'm by no means an expert compared to some members, such as Dr. Kobayashi. PET typically is used to measure metabolism through radiolabeled fluorodeoxyglucose. The uptake is slow, and therefore intraictal studies can only be performed. And in patients with abnormal findings, typically we see hypometabolism, unless they have a very, very active intraictal EEG, where sometimes you may see hypermetabolism. It does have, unfortunately, some limited usefulness in some patients with multifocal brain syndromes, especially those with frequent intraictal discharges. PET can also be used to look at binding of other receptors, such as GABA, serotonin, opioid, and dopamine receptors. So here's just an example of an
Dr. Federico, just to flag that there's a question in the participant. Susan Warner has raised her hand.
Oh, okay, thanks. I didn't see that. Okay, what's the question?
Susan, if you can unmute. And if not, I can pay attention to the chat section.
Okay, sounds good. And just let me know. So this is a patient with non-lesional MRI, although I wonder about this, who had a significant area of hypometabolism, which when superimposed upon the MRI scan can give you an idea about the area of hypometabolism relative to the patient's anatomical structures. Now I'm going to go back and review that case that I presented yesterday. So how does PET perform versus ictal SPECT? And I'll show you first of all my experience, and which I think is reflected in this case here. This patient had an outpatient PET scan in January, so well before he was admitted, and the initial report showed hypometabolism in the right temporal lobe, and that's where he had by far the most abundant epileptiform discharges. But as we know, his seizure here, which is a focal aware seizure, began in the posterior head region as identified there. And then when the nuclear medicine radiologist reviewed the PET scan again, he in retrospect identified an area of hypometabolism that was there all along that corresponded fairly closely to the ictal onset zone as determined by ictal SPECT here. So I think this kind of reflects my experience, particularly in extratemporal lobe epilepsy. But here's a more systematic evaluation of SPECT versus PET. This is an old study. It was actually a meta-analysis carried out by Susan Spencer way back in '94, comparing for temporal lobe and extratemporal lobe epilepsies, ictal SPECT, PET, and intraictal SPECT. So she found in this review of 291 temporal lobe cases, ictal SPECT has a sensitivity of 90%, which is greater than that of PET, which is 84, and intraictal SPECT, which is 66. The specificity, however, was the greatest for PET. For extratemporal lobe epilepsies, ictal SPECT actually outperformed PET by a significant margin, and that's really my experience as well, with an 81% sensitivity versus 33 for intraictal PET versus 60% for intraictal SPECT. And the specificities were all roughly the same for this. And I forgot to mention in this study here, they determined the relationship of these neuroimaging investigations with the seizure onset zone determined by scalp EEG. So here's another study, a more recent from 2013, which compared these modalities in 45 patients who had intracranial EEG confirmation of the seizure onset zone, who also had PET and ictal SPECT. And again, the numbers were quite similar, 95% sensitivity for ictal SPECT versus 82 for PET, and then 78 for ictal SPECT versus 30% for PET. So when should you use PET or SPECT? And this is really a big can of worms, okay? And here's a paper published by the Neuroimaging International Leading Epilepsy Pediatric Surgery Task Force. It shows this very complicated evaluation protocol for all different investigations, okay? I would ask you to maybe read this if you want for more information, but I'm just gonna give you some very basic possible approaches. So as they indicate here, if the seizure semiology by history or video, EEG, cranial MRI shows a lesion, the EEG onset, as well as integral discharges and neuropsychology, if relevant, are all concordant, point to the same area, then no PET or SPECT is really necessary. Where it becomes a lot more cloudy is if you have a patient with a non-lesional MRI scan. For example, if you take temporal lobe epilepsy, what many centers would do, including ours, if you obtain an outpatient PET, for example, and you see hypometabolism there, and then you get a clear mesiotemporal seizure on scalp video EEG monitoring with concordant intraictal discharges in a seizure onset zone consistent with the PET findings, then that may be enough information, especially if neuropsychology complements that. If there's any discordance between those findings, then one may consider intraictal and ictal SPECT. Even though ictal SPECT is probably a better marker of the potential seizure onset zone, we generally perform SPECT scans first because they're much easier to perform and less labor intensive. But there's all sorts of variations on this theme. You can have, a subtle lesion, and perhaps you want to identify the extent of the resection. So you might want to do an ictal SPECT, for example, or you may have a very large lesion and you want to identify, such as that patient I presented, and you want to maybe help identify a specific area in that identified lesion to resect. So this is very, very simplistic, but if you want to have a more detailed review, at least from a pediatric perspective, which I think is largely applicable to adults, I would refer you to this paper. So now let's change gears and we'll talk about advanced imaging methods. And yeah, we're doing pretty good for time, actually. So let's say you're evaluating a patient for epilepsy surgery and you've obtained a proper harness protocol, you've reviewed it carefully, and it's non-lesional. So there are a few ways you can go forward from here. First, you can take the same imaging data that you acquired and subject it to post-processing techniques. And this is, there are many techniques you can perform, and it depends on which center you're from. I would say arguably the Montreal Neurological Institute in Canada is heads above the other epilepsy centers for doing this to identify potential epileptogenic lesions. And some of the methods you can use, which I won't discuss, include voxel-based morphometry, feature detection, multiplanar curvilinear reconstruction, texture analysis, gray matter atrophy, amongst others. The other thing one can do is acquire different imaging sequences. Don't repeat the harness protocol, okay? You can obtain DTI, DWI, susceptibility weighted imaging, T2 reflexometry, such as in this patient that we published a while ago, and see if you can identify structural abnormalities using these additional sequences. Beyond that, you can use other non-structural imaging techniques such as functional MRI, and I'll talk about EEG fMRI next. And this can be used to identify the potential spike onset zone and seizure onset zone. We can use task-based fMRI to lateralize language, for example, and resting state network analysis is now really just in the realm of research. What I'll also talk about at the end is vascular imaging, which is an area of research of mine, which I'm hoping will become more broadly applied to identify the seizure onset zone. So of these advanced MRI methods, I now will finish off the talk with a discussion of scalp EEG fMRI and then vascular imaging. So scalp EEG fMRI offers several advantages. First, as you know, scalp EEG has a limited spatial sensitivity of approximately 10 square centimeters. Intracranial EEG has a greater spatial sensitivity, but it's limited in its spatial coverage that depends entirely on electrode placement. fMRI provides whole brain coverage, and EEG fMRI was actually first developed here in Canada, in London, Ontario, by Ives. It actually offers the advantage of the great spatial resolution of fMRI and the excellent temporal resolution of EEG. And here's an example of an EEG fMRI cap that we use in our center. It's commercially available. It's basically a 64-channel cap made of non-ferromagnetic materials. The patient has a cap placed on their head, and they're put in the bore of the scanner, and they're asked to lie quietly, fall asleep, while EEG is recorded during the acquisition of fMRI images. So here's what the EEG looks like in the scanner without any processing. It's a complete mess. And this is all MR gradient switching artifact that obscures the entire EEG recording. But with the proper decimation and artifact removal and remontaging of the EEG, you can get very good looking EEG where epileptiform discharges can be seen. So the next step then is to have two experienced EEGers review the EEG and mark the timing of these intracranial discharges. And then the timing of these discharges is used to perform the fMRI analysis, where what's called the canonical hemodynamic response function, which is a predicted fMRI response to a single discharge, is used to generate statistical maps of brain activation related to the occurrence of these intracranial discharges. And the signal we measure is called the blood oxygen level dependent signal. And what you can see is that seemingly focal discharges, such as this one in the right posterior temporal parietal region, can have the maximum bold response in that region, but there's also areas of bold signal increases in distant cortical and subcortical regions, which suggests that cortical and subcortical circuits may underlie the generation of epileptiform discharges. And a lot of work from a lot of centers across the world have provided insight into the networks underlying the generation of epileptiform activity. But for clinical purposes, scalp EEG fMRI may also localize the seizure onset zone and may be a really good marker of the potential epileptogenic zone as well. So I'll just review one study from the Gottman lab published in 2012, a very nice study. They studied 33 patients who underwent scalp EEG fMRI, and here's the results of one patient who had right frontal epileptiform discharges and a bold response in the right frontal region. In this case, the MR images are displayed in the anatomical orientation. So the maximum bold response here was concordant with the scalp EEG localization. So of these 33 patients, 88 had a bold response that was concordant with the EEG localization, such as I showed here. Of the 33 patients, the EEG fMRI results contributed to the definition, to defining the seizure focus or the target of surgery. Now, some patients had an abnormal structural MRI, and some underwent intracranial video EEG monitoring, and that was 14 in total. And of those 14 patients, 86% of them had a bold response that was concordant with either the ictal onset zone, as defined by intracranial EEG, as shown in this case with the depth electrode, or with the structural MRI result. So I think this study very nicely shows that scalp EEG fMRI can identify the seizure onset zone. What about predicting post-surgical outcome in the potentially identifying the epileptogenic zone? So another study by Anne, very nice study from the Gottman lab, evaluated 35 patients who underwent scalp EEG fMRI and epilepsy surgery. And these patients were divided into 4 groups based on the location of the bold response, and the resection. The first group was determined to be fully concordant, where the maximum bold response was actually included in the resection cavity in the resection in its entirety. And then there's a partially concordant group in which more than 50% of the maximum bold response, but not all of it, was included in the resection cavity, as can be seen here. Then there's a partially discordant group where less than 50% of the maximum bold response was included in the resection. And in the last group was a fully discordant group in which the resection here did not involve any of the maximum bold response. So they then took the fully concordant group in which the entire bold response was included in the resection, and the fully discordant group, and evaluated the ability of these two groups to predict post-surgical outcome, either good outcome or poor outcome. And they found that scalp EGF MRI in these two groups can predict post-surgical outcome with a sensitivity of 87.5%, specificity of 76.5%, as well as a positive and negative predictive value of 70 and 91%. So again, scalp EGF MRI can very nicely predict post-surgical outcome. So here's another study that predated the two that I just mentioned, which I thought was really good. And this was from a Dutch group, which showed that perhaps scalp EGF MRI can help patients who are seemingly hopeless, unfortunately. So they took a group of 29 patients that were deemed ineligible for epilepsy surgery by conventional means, and they all underwent scalp EGF MRI, and 8 patients had bold responses that were concordant with the location of the interictal discharges. So they focused on these 8 patients. These 8 patients were deemed to be non-surgical candidates because either they had an unclear surgical target, presumed multifocality, or both an unclear focus and presumed multifocality. When they looked at the patients that had an unclear focus, there were 6 patients, and the scalp EGF MRI data in these patients improved localization in 4 of them. In patients with presumed multifocality, scalp EGF MRI advocated for single focus in 1 patient, but confirmed multifocality in 4. So of these 4 patients, all 4 of them, I should say, underwent intracranial video EEG monitoring, and those data supported the EGF MRI results in 2 patients who underwent surgery with a good post-surgical outcome. So even though it's not a great result, I mean, out of 29 patients that were deemed to be ineligible for epilepsy surgery, going through this process resulted in surgical cure for at least 2 patients. So I do scalp EGF MRI in the past, but now I've actually been performing intracranial EGF MRI, and this is less commonly performed, only 2 centers. But intracranial EGF MRI actually offers the advantage of more precise recording of epileptiform discharges and even the possibility of recording high-frequency oscillations. This also will allow us with intracranial EGF MRI to obtain an increased number of discharges for the analysis. And this will increase the statistical power of the study. So here's just an example of an early study from 2012 when we used to do subdural recordings of a patient that had bilateral mesiotemporal epilepsy, non-lesional. And here, the location of the discharges are shown in the red squares here. And this is work performed by one of my graduate students, Cam Cunningham, and my research associate, Dan Pittman. What you can see are the independent spikes in the left and right mesiotemporal regions in the seizure monitoring unit recordings. And here you can see very nice EEG quality during the acquisition of MRI scans, where the discharges are very clearly identified over the left and right mesiotemporal regions. The bold response in this patient is shown here. The green dots indicate the location of the discharges, and here we see very localized activation to the actively spiking contacts in the left and right side. And I won't discuss these other activation patterns for now. But this isn't the response that we've seen for most patients with mesiotemporal discharges. In fact, another PhD student of mine noted that patients with non-lesional temporal lobe epilepsy seem to have 1 of 2 types of patterns of bold responses to seemingly focal epileptiform discharges. The first were patients that had very localized activation, where you see the active contact here and the maximum bold response in the vicinity of the active contact. This is a patient with independent epileptiform discharges and seizure onset zones. Another one with independent epileptiform discharges and unilateral discharges. This group of patients, we now got 5 like this. I'm just showing you 3. contrasted another group of patients that had much more widespread activation to seemingly focal discharges. Again, you can see activation immediately adjacent to the contact, but there's also widespread bold signal increases in a variety of regions. And these areas correspond to resting state networks such as motor, visual, and default mode. And it's really quite striking the difference between these two patient groups. And so we tried to understand better why this could be. And so we looked at the studies themselves. We didn't acquire more discharges, for example, in this study compared to that. So an equal number of discharges were acquired. The morphology of the discharges was relatively similar. Their ages, duration of epilepsy, medications were all relatively the same. But only one thing we found stood out, which was a bit surprising, and that is the frequency of bilateral tonic-clonic seizures. And unexpectedly, those patients with frequent bilateral tonic-clonic seizures had the more limited bold response to focal epileptiform discharges, whereas those that had much more rare epileptiform discharges had the much more widespread bold response. So this was really a surprising and perplexing result, which we're still kind of struggling to understand. So as I mentioned, because we have intracranial EGF MRI, we can also look at high frequency oscillations, which you probably know are arguably maybe a better marker of the epileptogenic zone than intracranial discharges. So in the same patient, as I'll show you here, we're able to look at the bold response to intracranial discharges. And this is one of those patients that had widespread activation. So we also recorded HFOs in the exact same patient. And here's the bold response that we saw in fewer events. We can see that that typically high frequency oscillations are associated with a much more limited bold response in this patient compared to the intracranial discharges. And what's interesting here, I forgot to mention, is it's difficult to see any bold response immediately in the location of the electrode because of signal dropout. But what we can see here is that we're presuming that HFOs are being recorded, are present here, but we identify areas in the brain where HFOs probably exist as well. So it's possible in the future, and we're doing a study for this, to see whether maybe we can use the EGF MRI data to help tailor resections to include these other areas of the brain that don't have EEG electrodes directly implanted into them. Okay, so for the last part of the talk, good, I think we'll finish on time. I'll discuss post-ictal hypoperfusion. And this is a phenomenon that's probably not familiar to most of you who aren't from Calgary, but this is something that really came to light through some work through a basic scientist in Calgary. So as we all know, seizures can be followed by transient neurological impairments, such as Todd's paresis, post-ictal aphasia. There's several case reports of post-ictal hypoperfusion in the past, so starting from the work of Penfield and Jasper, who identified changes in vascular caliber during the performance of neurosurgical procedures. But then a case report in 1975 of a patient that had prolonged Todd's paresis, who had a cerebral angiogram performed during that time, showed reversible vasoconstriction in the hemisphere contralateral to the paretic limb. And subsequent case reports using CT perfusion also show hemispheric hypoperfusion contralateral to the paretic limb in someone with a prolonged Todd's paresis. And MR perfusion techniques in another case report show that as well. So these few case reports show that post-ictal hypoperfusion can exist in patients with very significant Todd's paresis. Now, in 2016, the Teskey lab, working with hippocampal seizures, and I contributed to this manuscript as well, made the remarkable discovery that in hippocampal seizures, so this is an extracellular recording of a stimulus-induced seizure, while measuring oxygen levels in that hippocampus, you can see significant drops in oxygenation that during the seizure, which then increases, but then returns to the severe hypoxic range below 10 millimeters of CBF units. So this is severely hypoxic for up to 60 minutes before returning back up to baseline. So essentially the hippocampus is stroking out, if you will, for an entire hour. And Dr. Teskey was able to show that the duration and extent of the severe hypoxia is directly proportional to seizure duration. It's also repeatable in the same animal for different seizures as well as different animals. So it's a very reproducible phenomenon. He also, in some other animals, measured the blood flow, shown in red here, and showed that at the same time as there is significant reduction in PO2, there is profound hypoperfusion as well. So with these data, we wanted to explore the possibility of whether post-ictal hypoxia can be seen in humans. So in a few patients who were undergoing stereo EEG, shown by the red dots, whose seizure onset zone was shown by green here, we implanted an oxygen probe in the right hippocampus. And during a recorded seizure shown here, we found that oxygen levels actually decreased, much like the case in animals. And it continued with a transient increase after the seizure terminated, just like we saw in the animals, followed by another decrease for approximately 20 to 30 minutes before returning back to baseline. So taking this one step further, we sought to determine whether we can measure post-ictal blood flow across the entire brain using arterial spin-labeled MRI. And this was work carried out by Dr. Shaili Singh, who was an epilepsy fellow at the time in Calgary and my research associate. And this study was easier said than done. We took 21 patients who were undergoing scalp EEG monitoring, and as soon as they had a seizure, we removed their EEG electrodes and rapidly transported them down to the MRI center to try and get an MRI measurement of blood flow within 60 minutes of seizure termination. We then also obtained a baseline scan, much like we would do with ictal SPECT and intraictal SPECT. And similar to SPECT, we obtained subtraction maps where we took the post-ictal measurements of blood flow and subtracted that from the baseline blood flow and superimposed the differences onto their anatomical MRI scans to give images such as this. So I'll show you two examples. This is actually our very, very first patient we ever studied. This patient had a left mesotemporal dysplasia, focal impaired awareness seizure arising from the left anterior to mid-temporal region. The seizure lasted only 70 seconds, and we measured blood flow 54 minutes after the seizure ended. And what you can see here is profound hypoperfusion 54 minutes after the seizure ended. And if you remember that normal CBF blood flow in the gray matter is 70 millimeters of mercury per 100 grams per minute, or CBF units, you can see here that this is actually 50 CBF units down. So it's quite profound, even 54 minutes after the seizure ended. Here's another patient with a normal MRI scan that had a left frontal focal impaired awareness seizure lasting 2 minutes, and blood flow measurement 53 minutes after the fact showed a focal area of hypoperfusion in the left frontal opercular region. And this corresponded fairly reasonably with an ictal SPECT obtained for the exact same seizure. So this patient actually had an ictal SPECT, went to the MRI scanner, and then went to the nuclear medicine department to measure the exact same seizure. So in the 21 patients we studied, we found significant post-ictal hypoperfusion in 71% of our patients, and these results were concordant in 80% of them, but 29% did not have any significant blood flow changes. Now, I won't show you the data, but we also extended this study to measure blood flow using CT perfusion, which is much more easy to perform, with the hope that perhaps we can use this more widely for clinical purposes. And we essentially replicated these results. So CTP can measure post-ictal hypoperfusion fairly well. So take-home messages. First and most importantly, as I said, remember that slide, use the harness MRI protocol for persons with epilepsy. Provide the neuroradiologist with all relevant clinical information. SPECT and PET are important tests in epilepsy pre-surgical evaluations with the caveats mentioned. Scalp EEG fMRI can help identify the seizure onset zone and epileptogenic zone. Intracranial fMRI can also provide unique insights into the epileptogenic networks. And it is my hope that post-ictal hypoperfusion may be shown in a larger group of patients to localize the seizure onset zone and hopefully be used more widely clinically. And with that, I thank you for your attention.
Great, thank you. I'm sure there's a global virtual applause